Okay, so let's look at this individual. This is the thing about the internet that's not fair, is people out in public can be filmed doing whatever they're doing. And, we've had 15 seconds now of looking at this individual. Let's do an analysis. He has an ankle bracelet on, which means he's on parole or probation. He's in his bare feet. He is dressed appropriate for the weather. He is acting in a manner as though he's talking to someone on the phone. As you just saw, his feet are very, very dirty. And he is holding, appears to be an unlit cigarette butt. I don't see it lit. I don't see him smoking. He is moving in a consistent pattern of looking for stuff and walking around. I'm guessing he's picking up cigarette butts. What is associated with tobacco use, high tobacco use? What mental health disorder is directly associated with the nicotinic receptors of the brain? Okay, so you should be able to diagnose this now. It's only been 1 minute and 10 seconds. If you can't diagnose this person within 3 diagnoses of what's the mental health disorder that's a billable code under the Diagnostic and Statistical Manual of Mental Health Disorders, well, sorry. You're not qualified to be a clinician because you can't differentially diagnose. So let's find out. Now, we've had 1 minute of observation of an individual, and we have reason to believe he's searching for nicotine. He's looking for cigarette butts. He's acting in a manner as though he's apparently talking on a telephone. I'm going to guess he's not actually talking on a telephone. The telephone is a device that makes him appear a little less mentally unstable, but I've got it down to 3 diagnoses. I'm pretty sure it's schizophrenia. Who's in agreement? This is the differential diagnosis is directly tied to schizophrenia. Nicotinic receptors in the brain, which are activated by nicotine, which makes people who are schizophrenic fairly easy to differentially diagnose by starting off with the fact that they will smoke tobacco like you've never seen. Oh my God. Whenever I was around schizophrenics in downtown Stockton, I used to do 5150s down there, right? And so you find the schizophrenics, and man, as soon as you let them out of the hospital room, as soon as they get a chance to go find nicotine, they'll do anything. They'll chain smoke every single cigarette they find out of ashtrays, garbage cans, wherever, if they're highly schizophrenic and highly nicotine seeking. So here's the problem. Smoking obviously shortens your lifespan. The average lifespan of a schizophrenic is something like 46 and a half years old. This is a fairly severe form of schizophrenia. Now, here's my differential diagnosis. Obviously, methamphetamine or stimulant or brain injury or toxic levels of something in the blood or system. Acute, meaning short-term, acute onset of a psychotic disorder as a result of using some substance. Definitely a rule out. But let's look at the individual. He has fairly good posture. He's fairly strong. We're 3 minutes and 20 seconds in. He's able to get up and down, move around. He appears to be on a phone. However, I'm not noticing that he's actually communicating or talking with anyone. And he puts the phone down consistently on a pattern of when he's trying to pick up cigarette butts. So before you even walk up to somebody like this, and before you even start talking to somebody like this, and before you start doing your differential diagnosis face-to-face, you should be able to come to pretty much the entire DSM-5, and you've got it down to like 3 things. And you're going to go in and differentially diagnose for 3 things. Obviously, you're going to look for acute substance abuse of some sort, whatever it is. The dude might have had 4 edibles. We're in Northern California, by the way. It takes exactly 30 seconds to find weed where I'm at right now. 30 seconds, okay? And I'm not saying because it's close nearby me. It's everywhere. 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 Now you're going to look at this lady over here by her vehicle who seems concerned. How do we know she's concerned? She's staring at him. She's looking at him. That's a predatory move, but it's also a curiosity move. Maybe she's just curious, but she's clearly concerned because she's paying attention. Now we're at 4 minutes and 43 seconds, and if you don't have this down to schizophrenia, and you're pretty sure you don't know how to differentially diagnose schizophrenia, you should not be a licensed clinician allowed to practice. You shouldn't even consider anything else without ruling out schizophrenia. So that's why when you do 5150 assessments, or you're working in mental health and you really think you know what's going on because somebody put a label on somebody or somebody did not put a label on somebody. Now let's suppose the label that gets put on this guy because he's using substances is addiction. And let's suppose that people assume he's high on meth. There's no breathalyzer, methylizer, there's no goddamn there's no breathalyzer to determine if he is or isn't acute intoxication. I can't stick a needle in his arm, but I can look for symptoms. What I would look for symptoms of a person who's on meth is agitation, lots of moving, talking incessantly, somewhat psychotic, and acute is psychotic, and so super high. But he's looking for something, and let's just say that's not fair. You're over-judging him. You're judging him as though he has a mental health disorder that's more long-term. Schizophrenia is long-term, and incurable. Schizophrenia is incurable. And you're giving him something more severe than you should. Okay, sure, fine. Let's suppose that he is intoxicated, or he does have residue levels or metabolites or whatever. It could be alcohol. I've seen people do this on alcohol. Alcohol psychosis, especially. Oh my God. You see alcohol psychosis, watch out. It's fucking dangerous. If somebody's in alcohol acute psychosis, they are completely, sometimes completely psychotic, and they will 100% fool even the most experienced emergency room doctor. And the most experienced of experienced emergency room doctors will call this acute intoxication, and then they'll rule out all the other shit because, in fact, maybe he is intoxicated or he's coming down off something, but if he has the DTs, the delirium tremens, the withdrawal symptoms of alcohol addiction, actual addiction. So when they go off alcohol, they become psychotic. This is easily medically managed for the most part. I have seen people die coming off alcohol who were very healthy people. Police officer in Stockton, oh my God, dude was in his 30s, healthy as hell. Fucking came in, I think he was 26, whatever, man. He used to drink like 3 fucking 12 packs a day. That's a very stressful job. He was a young man. He had a child going through a divorce, had a tough time, came in to get cleaned up. He was dead by the next fucking morning, man. He was fucking dead by the next fucking morning, because even in a hospital setting, it was very difficult to manage the seizures that can happen from acute alcohol withdrawal. It could kill people and fry their brain. So we got to look at brain damage. That's my other one. So you got schizophrenia, number 1. You have acute intoxication and or withdrawal of a substance. That's number 2. I'm gonna have to throw another number 3 in there because I think it's more important than brain damage. Because how the fuck what are you gonna put him in a fucking scanner? You got to be able to do your 5150s without even talking to the person. You got to be able to do it before you even walk in the room. You got to be able to do it, because if you can't, by the time you get in there, you're not going to be able to rule in acute withdrawal or intoxication of a substance. And the other one that's right next to that, kind of a 2A and 2B, I would say, is off their medication. Because you got to look at legal stuff too. If he's let's just say he's bipolar. Okay, let's throw bipolar in there. I don't know why, but let's just throw bipolar in there. So definitely you want to be able to do a rollout for any other psychotic disorder, such as bipolar disorder. I have never seen a person in a psychotic phase of bipolar disorder go out of their mind trying to find cigarette butts and smoke cigarette butts. So if you're really want to get back to something that I really, 46 years old, average age of schizophrenics. They will do things like, if they see something they don't want to see, they'll poke their own eyes out. If they hear stuff and it's hallucinatory, they'll pop their own eardrums. I've seen them take I haven't seen it happen, but in multiple cases I've seen where schizophrenics are permanently blind because they have gouged out their own eyes and or ears, and it's very stressful for me to tolerate that. Looking at somebody who's done that, and here's the sad part, it does not make the schizophrenia go away. So if you sever the nerves of the eardrum, you would think, well, then they won't hear voices, right? Nope, that don't work that way. Unfortunately, they still hear voices. All right, so here you are, 10 minutes in. And I'm 100% confident